Welcome to the Lower Extremity DVT POCUS examination overview lecture. So to perform this examination, no patient preparation is required. You will normally use a high-frequency linear transducer. However, in patients with larger legs where you're going to have to penetrate greater than 7 to 8 centimeters in order to visualize the desired vascular structures, and you can use a lower frequency 5 to 2 curvilinear probe. Patients should be positioned supine with their leg externally rotated. The bed can be placed in a reverse Trendelenburg position to promote venous pooling, and this is primarily a grayscale compression examination. And here you can just see an example of a linear probe being used, and here's an example with a curvilinear probe being used. Both of these patients had DVTs, so again, it's going to be based on probe availability as well as the depth of the target structures. There are multiple different protocols out there for lower extremity DVT evaluation. POCUS protocols focus on the proximal veins. We're not saying that the risk is non-existent for isolated calf DVTs to embolize or to propagate. It's just that a comprehensive full leg exam is going to be much more time consuming, and that's usually out of the realm of what most POCUS users are going to be able to spend in terms of their exam time. And when we break it down even further, looking at just the proximal exams themselves, you can do 2-point, 3-point, or continuous. 2-point where you compress up here for the common femoral vein and popliteal vein, 3-point common femoral vein, mid-femoral vein, popliteal vein, or continuous where you will scan the entire venous system proximally and then intermittently compress at 1 to 2 centimeter intervals. That's the one that we're going to discuss here. I think that is the easiest one to do. Well, yes, with all of these proximal protocols, you're going to miss isolated calf DVTs. With a comprehensive protocol proximally where you scan at 1 to 2 centimeter intervals, you're not going to miss focal DVTs. Do you need to do duplex or triplex evaluation? Again, the heart of this examination is transverse compression grayscale scanning. One area where I do think Doppler can be helpful, beyond just helping you to identify the vascular structures in difficult cases, would be if you have a concern for a very proximal iliofemoral thrombosis. You may not see grayscale evidence of thrombus within the lumen or absence of compressibility, but something that may clue you in that there is a more proximal obstruction is that you lose respiratory phasicity in the common femoral vein. So that's one area where I think the use of Doppler can be helpful. Do not rely on this to tell you yes or no to the presence of flow. You could have the incorrect settings. Here you've got definitive grayscale evidence that there is a DVT there, but with incorrect settings, I could make it bleed over the top of that and make it look like there is pseudo flow. So just be careful of that. So again, this is going to be a compression examination. It's like celery chopping. Your probe is going to be held anteriorly on the thigh, unless you're doing the popliteal vein, and you're just going to compress in an anterior-posterior direction in the transverse plane. Do not do this in a sagittal plane. So how much compression do you need? Not as much as you would, as you think you would need. Here's somebody that does have a DVT, and you can see the vein is not tenting, but you've got tenting of the artery. So if you've got tenting of the artery, then your compression is way more than adequate. And more importantly, if you've got grayscale definitive evidence that there's a clot there, there's always the potential risk for embolization due to compression directly over the area, so I would avoid that. So here's the exam. You're going to start off high up in the groin, and you're going to identify common femoral artery, common femoral vein. And that's where you begin your celery chopping. and then you move down at 1 to 2 centimeter intervals. So you can see here, artery, vein. So we're going from lateral to medial. And as you slide down, you're going to notice that the artery divides first, and then you're going to find where the greater saphenous inserts. And this is an important point here because while, yes, a greater saphenous is a superficial vein, presence of a long segment clot there that's greater than 5 centimeters or within 5 centimeters of the insertion point, unless there's contraindications, it's usually recommended that these patients be treated with anticoagulation. So here you can see anechoic lumen, and the vessel's compressible. You can see that there's a valve right there that's not a clot. Now you're just going to continue sliding caudally, following the vessels down. You're not worried about the deep system. You're continuing to follow the femoral artery and femoral vein. And the vein is going to be deep or posterior to the artery. At this level, it's important that you look for the presence of venous duplication, which can occur in a significant minority of patients. And it's very easy then, if there is a clot within an isolated duplicated system, that you could miss that because it's going to look very similar in echogenicity to the surrounding soft tissue. And here's just an example here of a patient with a duplicated system. There's no clot within this system here, but here this patient had a chronic clot, and then here's the artery right there. So you can see the vein is at 9 o'clock in the 6 o'clock position. This isolated system had thrombus. You're now going to continue moving down. As you get towards the adductor canal, you're going to have to use your free hand to reach behind to compress. Now, while you can visualize using a more medial approach, most prefer doing a more anterior approach. And with that approach, you will definitely not be able to just directly compress. You're going to need to use your free hand. For the popliteal vein, you can have the patient bend the knee, and you can put the probe directly behind in the popliteal fossa with the indicator towards the patient's right. Since you're now scanning posterior to anterior, the popliteal vein is going to be seen in the near field. And you're just going to continue your compression and follow that down until the femoral vein or the popliteal vein divides. So what is a blood clot going to look like? In acute DVT, it's going to have an enlarged vein. It's going to be non-compressible, and you can see the echogenic lumen here. The vessel is enlarged compared to the adjacent artery, and it's non-compressible. A very hyperacute thrombus could be anechoic or very hypoechoic in appearance, but most are going to be echogenic and identifiable on grayscale imaging. Here's another example here of a femoral vein DVT, echogenic lumen, non-compressible. Here's one as we're getting close to the adductor canal. So artery, vein, echogenic lumen. And here's one more where the most proximal part of the clot within the vein was down at the level of the adductor canal, and you can see it now starting to fill the lumen. Here's a popliteal vein DVT. So again, since you're scanning posterior to anterior, the vein is going to be in the near field here. While not a mandatory part of the exam, here we're able to identify sagittally, here's where the free edge is of the thrombus within the common femoral vein. So can you differentiate an acute from a chronic DVT? I'll say at best that that's difficult. If you've got prior imaging and knowledge of the patient, that's definitely going to be helpful. But to go in there, and I try as a POCUS user to differentiate acute from chronic DVT, that's probably a slippery slope right there. Now, there are some sonographic differences, but again, it's not a very clear-cut black and white. Chronic DVTs, the veins appear smaller or maybe normal in size. They can have thickened walls. They can still be compressible, and they may have echogenic web-like filling defects within there. You can see here's a patient with a chronic DVT. You can see that there's been recanalization and that the thrombus is now more eccentrically located towards the wall. But just be careful there. Again, greater saphenous, lesser saphenous, they're not deep veins, but they can hold a fairly significant amount of clot burden. So long segments greater than 5 centimeters or thrombus within 5 centimeters of insertion into the common femoral vein for the greater saphenous vein, unless contraindicated, those usually are treated with anticoagulation. And so here you can see that there's a clot in the greater saphenous vein in proximity to the common femoral vein there, and it's a long segment. And here it is sagittally as we're following it down. It was much greater than 5 centimeters in length, and this patient was treated with anticoagulation. What are common incidental findings? Well, Baker's cysts. These are synovial cysts that you're going to find posteriorly. They communicate with the posterior bursa around the knee. You'll find them between the medial head of the gastroc muscle and the semimembranosus muscle. And these can, clinically mimic a DVT when they rupture. And when you scan them sagittally, they have a bird beak type of an appearance. They can be anechoic or complex in appearance. Also, be careful about venous stasis. You can see in patients with kind of slower flow states that they can have this spontaneous echo contrast that could mimic a clot. So here's a patient that has spontaneous echo contrast there. It's compressible. There's no clot. But as we move down, now you can see that there is a clot. These do not have to be associated with a clot, but this patient did have both. So I wanted to have that on there for comparison. Inguinal adenopathy. So you can see echogenic foci with internal flow if you put Doppler on there. These are obviously going to be non-compressible. Unlike a vascular structure, these are going to be a fixed length from a cranial to caudal and anterior to posterior direction. And they should not be adjacent to an arterial structure such as a deep vein would be. And here you can see in a patient with CLL that they've got multiple enlarged lymph nodes that, just freezing on one, view of this could be very confusing and make you think that there was a thrombus there. But again, identify it with the adjacent deep, or with the adjacent arterial system. And that concludes the overview POCUS lower extremity DVT lecture.